In this lecture we're going to be looking at angina and ischemic heart disease, and we'll have a little chat about what are the symptoms of angina, how do those symptoms come about, and then we'll move on into the pharmacological aspect and looking at the drug therapies that can be used to treat angina. In ischemic heart disease, the problem is in the delivery of the blood to the heart through the coronary arteries. At rest, the heart should get around about 5% of the cardiac output. That means that the blood that's pumped out by the left ventricle into the aorta then goes all around the body, branches off into all the various arteries. One of those that it branches off into is the coronary artery, and then the coronary artery that supplies the muscle of the heart. And so 5% of the cardiac output leaving the ventricle through the aorta goes to the heart itself. Now the blood that's coming in through that coronary artery is if you like, the tissue can extract about 75%, about 3/4 of the oxygen that's in the blood can be extracted from the perfusing blood into the heart to actually be utilised. And so with exercise, what happens is the blood flow through the coronary arteries will go up, because as we exercise, the heart needs to work faster, needs to work stronger, and if the muscle's been asked to do more, then what you need to do is you need to give it more supply, more oxygen and glucose supply to make the ATP, to get the energy source to fuel that extra work. And so therefore that's why the coronary artery blood flow is increased. Now, if there is a restriction of blood through the coronary artery, which can be done by the build-up of a plaque or an atheroma, that will narrow the coronary arteries, so when you're trying to step up the extra blood supply to meet the new demands, you can't supply enough blood through these narrow arteries. And so therefore you get an offsetting of supply and demand. The demand goes up, but the supply can't rise at the right rate to meet that new demand. Now, the plaques will form, usually they tend to form in parts of the vessels that are most susceptible. So where there's a bend or a curve in the vessel, where there's a branch and a bifurcation or a splitting, then what happens is you get the plaque forming there, and therefore you'll get a portion of the arterial wall will be free of the plaque, and another portion of the wall in the same area will have the plaque attached to it. Because not all of the wall is, if you like, infiltrated with a plaque, that means that the parts that are free from the plaque can still respond to vasoconstrictor influences, because the drugs and vasodilator influences, because the drugs can still get to the actual endothelial cells. If the vessel was completely filled with a plaque all the way around so that all the vessel wall was covered, it would be harder to get a drug to have a dilator effect. And you'll see that we need that dilator effect in order for our angina drugs to actually have a beneficial effect. Now, what can also happen is you can also get portions of the blood vessels that will be more prone to a vasospasm, and so therefore you can get a constriction. And so what happens then is you will get damage done to the vessel. So if the coronary artery disease is long-standing, then smaller parts of the vessel can develop and improve perfusion, sort of almost like a naturally occurring bypass. But that's only if it's long-standing. If you've got short-acting or short-lasting problems, then you will get a narrowing of the vessel and a reduction in blood supply, and the supply will no longer meet demand. The atheroma, or the build-up of these plaques, it would be a natural part of ageing, but it can occur in younger and younger people, and the risk factors for it is people who smoke, people who have high blood pressure, and people who have high cholesterol or hypercholesterolemia. And so therefore you can see immediately that some of the treatments will be non-drug related, if you want to call it that, insofar as you can stop smoking and see if that has an impact. But you've got the drugs, you might also see that if you were to lower cholesterol, which can be done by dietary methods rather than using statins, which are cholesterol lowering drugs, and we're going to come on and talk about those shortly. But the statins might lower cholesterol, the antihypertensives might lower blood pressure, and smoking would be another approach. So there's various approaches that you can take to minimise the risk of a plaque build-up. Now the plaques that you get can either be stable or unstable. If a plaque is unstable, that means there is a likelihood that the surface of the plaque can be ripped off. And that exposed plaque, the blood vessel will perceive that as being damage to the vessel wall itself, and what it will do next is it will form a clot around it. And that clot could then block the whole vessel completely, and that could lead to what we call a myocardial infarction or a heart attack. Now, in stable angina, that's when what you've got is a reversible myocardial ischemia. That means that the vessel is narrowed, and it's reversible because the problems only arise during periods of exertion. So at rest, everything should be fine. But when the person then starts to do anything, the demand can go up and the supply can't keep up because the blood vessel is narrow. And that would manifest itself as a chest pain or a pain radiating down the arm. But unlike a heart attack, which could have similar symptoms, if the affected person was to stop doing whatever it was they were exerting themselves in, then it should subside. And that's why it's called reversible. Now, the symptoms are coming about because of the imbalance between oxygen supply and oxygen demand. So there's a part of the heart muscle that's requiring more oxygen delivery because it's doing more. And the coronary arteries that are supplying that area are narrowed because of the plaque, and they can't supply the extra blood. So what we've got there is just a little diagram. Decreased oxygen supply, increased oxygen demand gives you an imbalance. Now that increased oxygen demand is coming about because the heart rate's up, the muscle contraction is up, or there might be changes in muscle tension in the wall of the heart. All of those increases mean the heart is working harder. And if the heart's working harder, the heart muscle needs more energy. And so therefore, the blood supply should go up with it. But if you've got the changes in vessel caliber, that means that the coronary arteries will be narrowed, and therefore this will go down rather than up. So if the vessels are narrow, the heart, all of these things are going up. You want this to go up, the blood flow to go up, but that won't happen because you can't open up the vessel enough, because the vessel is being narrowed by the build-up of the plaque. Now, in stable angina, that's basically when you've got the coronary blood flow cannot increase at the right level to meet the metabolic demands. And that's usually because a fixed plaque is narrowing the vessel. It's not that the vessel is blocked, it's only that it's narrowed. You can, however, also get a vasospasm, which is when the vessel spontaneously contracts and narrows. And that would occur, this one here, the stable angina, is more likely to be caused by an increase in workload and the blood supply not being able to keep up. Whereas if you've got the vasospasm happening, that can happen when the workload is normal or low. So it's not that you've increased the demand here, you've just reduced the supply. So in this one, in one version, the demand goes up and the supply can't keep up. In the other one, the supply goes down and can't meet the resting demand. Either way, you've got a supply-demand imbalance. There are also acute coronary syndromes, and they cover things from unstable angina through to myocardial infarction. And myocardial infarction is when the vessel becomes completely blocked, and cells are then deprived of all their blood, they shut themselves down, and therefore large areas of the cardiac muscle will no longer be able to contract, and that puts an extra workload in the heart, and that can result in a heart attack. Now, what can happen for these coronary syndromes is, we said that the plaque has a cap on it, it's almost like it's got a coating on the outside. And if you get a local disturbance of blood flow, such as a high blood pressure, so if someone's got the acute coronary syndrome and is prone to a myocardial infarction, you could have a situation where what we have is, we've got an individual who has high blood pressure, has vessels significantly narrowed by plaques, and decides to take part in some sort of physical activity. That puts the blood pressure up, and the extra pressure coursing through the coronary arteries causes such a disruption within the vessel that it takes the surface of the cap away, and that damages the plaque. As a result of that damage to the plaque surface, the blood vessel recognises that as if it is damage to the vessel wall, like a cut, and causes platelet aggregation and the formation of a clot. and that narrows potentially shuts down the vessel completely. And once that, not only that, but you can get bits of that clot breaking off and forming what we call microemboli, and they can break off, be carried in the blood, and block smaller and smaller vessels further downstream, therefore causing smaller pockets of myocardial infarction further down the path. So if the vessel occlusion is incomplete, you get angina. If the vessel is almost completely occluded, then but still some flow, you will get angina at rest. So partial occlusion gives you angina on exertion. Almost complete occlusion gives you angina even at rest. And then obviously if the vessel occludes completely, you're into heart attack territory. And that's what we mean by myocardial infarction. And so we've talked through this already, but basically what happens is the occlusion is going on for such amount of time, the vessel is closed, and after about 20 to 30 minutes of the vessel being closed, the cardiac cells that should have been getting supplied by this will gradually start to shut themselves down, they will stop contracting, and that means that the rest of the heart has to take up the slack. So that's in the further increase in demand. And if the blood flow is not reinstated by using something like tissue plasminogen activator, or a clot buster as they call it, if that doesn't happen, then the cells that have gone quiescent and shut down the contraction will eventually lose the ability to hold themselves together, and those cells will die off, and you'll get areas of necrotic tissue. And that will show up as scar tissue on any future ECG. Now, the worst case scenario with that is that so much of the coronary artery, or so many parts of the coronary artery are occluded, and so many cells have shut themselves down and died off, that the rest of the heart is unable to support the function of the heart. The remaining cells can't take up the slack anymore, and that can result in sudden cardiac death or through a myocardial infarction or a heart attack. Now, thinking about angina, we'll move away from the myocardial infarction now. We're just thinking solely of angina. Now, in angina, let's take the basic example of the person only gets the symptoms of angina when they exert themselves. Now, most people will be aware of what their particular trigger is. So it might well be climbing sets of stairs, it might be doing a particular level of exertion. Now, that would only be a transient thing. So the effort's going up, the workload of the heart's going up, and the blood supply can't meet the demand. So you get two options here in terms of pharmacology. You can either increase the supply by the use of drugs, or decrease the workload of the heart, decrease the demand through the use of drugs. Now, these drugs are taken to relieve the ischemia during an acute attack, and they can be taken as a prophylactic after that to stop a further episode. So these ones would usually be taken, the person feels the exertion, they feel the pain in the chest starting, they take the medication. And then what they might do is they might take the medication later that day or over subsequent days when they're preparing to do some level of exertion, almost in a prophylactic way. Now, the drugs we're going to talk about fall into four major classes. And what they're doing is they're either increasing supply or decreasing demand. We've got the nitrovasodilators, we've got the beta-adrenoreceptor antagonists. Now, the beta-adrenoreceptor we're interested here is the beta-1 adrenoreceptor. And these drugs, the antagonists, are what you would be familiar with as the beta blockers. We've then got the calcium channel antagonists, which are sometimes referred to as calcium antagonists or calcium blockers. And then we've got the potassium channel openers, and we'll look at each of these in turn. The organic nitrates are probably the best known ones. Glyceryl trinitrate is what's known as nitrolingual, and it's the little pump spray that people spray into their mouth underneath their tongue. And that has a very rapid absorption, and therefore very quickly gets into the vascular system and has an impact. Other examples are isosorbide dinitrate and isosorbide mononitrate, and I've given you here in the brackets the trade name, the name on the packet as opposed to the chemical structure name. So what these do is, these vasodilators, they mimic the effects of endogenous nitric oxide. Now nitric oxide, when it was first found, if you like, if you want to call it found or identified, nobody knew that it was nitric oxide. It was referred to as endothelial-derived relaxing factor, or EDRF. We now know that that's nitric oxide. The reason it was called this, EDRF, is because it was noticed that there was this agent that was found in the endothelial cells of blood vessels, that when it was present, the vessel would relax or dilate. So it was called endothelial-derived relaxing factor. Subsequent research identified that what we were talking about here was ultimately nitric oxide. Now that was unusual because nitric oxide is a gas. People were thinking this EDRF would be some sort of transmitter, you know, like noradrenaline, acetylcholine or whatever, or it would be some sort of protein. It would be a major molecule, and actually it's quite a simple molecule, it's just NO, nitric oxide. Now, nitric oxide is an endogenous compound, meaning it's naturally found in the blood vessels. And what these nitrate compounds do is, when you take them into the body, they are metabolized, broken down, and one of the byproducts is nitric oxide. So that combines with thiol groups in the vascular endothelial and makes nitrosothiols. And those nitrosothiols, along with the nitric oxide, activate guanylate cyclase. And guanylate cyclase converts GTP, guanosine triphosphate, to cyclic GMP. And that conversion comes about because of the action of these two compounds here. So you get more cyclic GMP. Now cyclic GMP reduces the level of intracellular calcium. Now, thinking back to basic muscle physiology, in order for muscles to contract, you need actin and myosin to come together. And that comes about in response to an elevation of calcium within the muscle cell. So if calcium levels don't rise, actin and myosin don't come together, you don't get contraction of the muscle, rather you get dilatation. And so this gives a vasodilatation. These drugs work on the vascular smooth muscle to relax the vascular smooth muscle and increase flow. So what these ones here are doing is, these are ones that increase supply rather than decrease demand. And there's just a little bit of diagram there to show you what's happening. There's the nitric oxide being made, and the nitrates come in, so that's the natural mechanism. And the nitric oxide stimulates guanylate cyclase and gives you more cyclic GMP. So the nitrate drugs come in, they go into the cell, they mix and make nitrosothiols. That activates guanylate cyclase and makes more of the cyclic GMP. The cyclic GMP, what it does then is it blocks the entry of calcium into the cell and enhances the storage here. Now that pushing of calcium from here to there and stopping it coming in, that results in a lowering of calcium levels within the cell. Actin and myosin don't come together and you get muscle relaxation rather than muscle contraction. So what happens is you get the coronary arteries being dilated, you get the venous capacitance vessels being dilated, and you get the arterial resistance vessels being dilated. Now, the capacitance vessels, that means that the veins returning the blood to the heart dilate, and that reduces venous return. Now that means that the blood coming back to the heart, there is less blood coming back to the heart. So that goes back to the right atrium, down to the right ventricle, out to the lungs, back to the left atrium, back to the left ventricle. So if there is less blood coming back into the heart as a result of the opening up of the capacitance vessels in the veins, you will get less vascular filling, so less ventricular filling. So the preload will go down. That means the tension on the vessel, the ventricular wall will go down. So when the heart goes to contract, if there's less blood there, it has to contract with less effort to push the blood out. So the workload of the heart goes down and the myocardial oxygen demand goes down. And so that happens. So here as well, these drugs also have the ability to reduce the demand as well as increase the supply. So that the arterial resistance vessels are also dilated. And what that does is, that dilates the resistance, so total peripheral resistance goes down, and if total peripheral resistance goes down, cardiac output goes down, and cardiac output goes down lowers the blood pressure. And if that's happening, if the cardiac output is down and the blood pressure is down, the workload in the heart goes down. And so therefore there is a reduced demand, a reduced oxygen demand, and so you've also lowered demand. So the good thing about these compounds and why they're often the first line of defence is they dilate the coronary arteries to increase supply, they dilate the veins to reduce venous return, reduce cardiac output and reduce demand, and they work directly on the resistance vessels to lower blood pressure, which in turn lowers cardiac output, which results in a reduced demand. So these drugs are actually able to target both aspects. They can increase supply and they can decrease demand. And again, we've been through this already, how they work to reduce the blood flow, increase the blood flow by dilating the vessels. Now the pharmacokinetics of them, the best known one, the most widely used one is glyceryl trinitrate. It's very well absorbed from the gut, but most of the time it's taken orally and it gets absorbed through the oral mucosa into the bloodstream as a spray. It does undergo first-pass metabolism, and when it's metabolized, the metabolites are inactive. So once it's metabolized, it's lost its efficacy. Now, if you want to get, because it's well absorbed from the gut and because it would then be metabolized quickly, you're trying to find a route that you can give it that would then avoid that metabolism to make it work for longer before it's broken down. So it can be given sublingually, and that's the little tongue or the spray, tablet or under the tongue or a spray, and when you put it in, and it's just absorbed through the mucosa. Yeah. You can take, you can actually take what they call a buccal one. So the aerosol spray is the one for the sublingual. The buccal one is where you take the tablet containing the same thing. It's in a matrix, and you hold it between the upper lip and the gum. But basically in at the front of the mouth, under there. And if it's held there, it will permit a slow release of the drug. And what that does is it's quickly absorbed, but because it's slow release, it gives you a longer duration of action. So this one, the buccal route compared to the sublingual, they're both equally as effective. It's just this one, though, will last a little bit longer. You can do transdermal, and that would be through a patch or a matrix. And that gives you a steady, stable release of the drug, giving you a constant blood concentration for at least a day after you put the patch on. So that would be a way of giving you a constant level there. So you're not just taking this in response to an angina attack. And then, obviously, you can give it intravenously. Although that would probably be the least obvious way to give it, because you're usually looking for something that's an ease of delivery rather than a more complex delivery. But all of those would bypass the gut and therefore bypass first-pass metabolism and therefore increase bioavailability. Now, because you're getting the venodilatation or the opening of the veins and the reduced venous return, that can also cause postural hypotension. There's less blood coming back to the heart. We said there's less to pump out, so it's decreasing workload. But if there's less coming out, there's less going up through the carotid and vertebral arteries into the brain, and that can cause a dizziness, a lightheadedness, and a postural hypotension. It can also cause a reflex tachycardia, which means that because the effect is to reduce the working of the heart can kick in and overcome that by beating faster. The arterial dilatation means that you will also be dilating not just the coronary arteries, but other arteries within the body, and particularly around the head. The vascular supply around the muscle in the head can cause a throbbing headache and can also cause flushing and reddening of the face. But the longer, with the long-acting ones, you develop a tolerance to these effects, and they shouldn't be as bad for as long. We're then going to look next at the beta blockers. Probably the best known example is atenolol. Now these drugs are also useful as antihypertensive agents, because what these ones do is they primarily cause a reduction of the workload of the heart by blocking the action of noradrenaline. You'll see there they've all got the same ending, OL. So you've got atenolol, propranolol, and pindolol. All of these are beta blockers, which means that they are beta adrenal receptor agonists, specifically beta 1. So what they do is they are competitive antagonists, so they compete for the beta 1 adrenal receptor with noradrenaline, and they block the cardiac beta 1 adrenal receptor and stop noradrenaline getting there. Now noradrenaline would normally drive the heart. Noradrenaline would usually work in the pacemaker to make the heart beat faster and work in the ventricular muscle to make the heart beat more strongly. What these do then by blocking that action of noradrenaline is they decrease the heart rate through an action of the pacemaker and they reduce the force of contraction. Now, what that means is, if you think back to what we're talking about here now, if you like, the blood pressure is equal to the cardiac output times the total peripheral resistance in the blood vessels. And the cardiac output is equal to the heart rate multiplied